The first and most important thing is actually their skin pathology. There's anatomical differences in skin of color patients.
Welcome to the Learn Skin podcast with me, Dr. Raja.
And me, Dr. Hadar, where we discuss all things skin.
Join us as we delve into the art and science of skin health in today's episode.
Hey, Raja, can you say the thing I told you to tell them?
Of course. We are board-certified dermatologists. This podcast is meant for educational and informational purposes only and is not considered medical advice, nor does it serve as a substitute for professional care by a doctor or other qualified medical professional. All opinions shared do not express the views of Learn Health, Inc. Let's get to the good stuff.
Hey, Raja, how are you today?
I'm doing pretty well, Hadar. You know, I've just been thinking, what if everything we looked around was just... You remember black and white TVs, black and white photos, and if we only did black and white, like what happened to color?
I know. It is interesting because in dermatology, we pay attention to every subtlety of color. In my training, I remember people said, it's not pink, it's purple. And I used to say, wait, are you sure? What do you mean? And so we pay so much attention to color of the lesions, but often we forget the color behind the lesions, the color of the patient. And so in the last decade or so, there's been really a revolution, if you will, in how we educate our trainees and how we think about the clinical presentation of patients who have skin that the color is not just black or just white and everything in between, but really adjust our vision to do that. And so today we wanted to dedicate an episode to talk about this, about clinical presentation in skin of color patients. And we thought, hey, when you and I just talk, it's okay, but can we elevate the conversation?
Oh, absolutely. And I think that's what it is, right? Now we know that there are more skin tones. It's not just the colors, but there are more skin tones. There's more diversity. And we have to be aware of this if we want to really take care of our patients, because our patients are becoming more diverse. But you and I aren't just going to talk about it. We're going to get someone in here that really is dynamic, awesome with patients, has such a great perspective within dermatology. This is Lakshi Aldredge. She is a nurse practitioner. She's practiced in Portland at the VA in the Dermatology Service for many, many years. And every single time I talk to her, I just love her approach to patients. But it's not just about patient care. She's also very active in the community. She's served as a past president for the Society of Dermatology Nurse Practitioners and the Dermatology Nurse Association. So, Lakshi, welcome to the podcast. We are super excited to talk to you.
I am so honored and excited to be here. This is just a phenomenal podcast that you both have created with the Learn Skin team, and I'm just honored to be a part of this conversation.
You know, Lakshi, this is very exciting to have you on. Before we dip into some of the details around diversity or skin tones or, giving us, your experiences and what we should know, can you tell us a little bit about yourself and what took you into dermatology and what is a dermatology nurse practitioner? A lot of people might be thinking, should I go down the MD route or the DO route or the PA route or the NP route? And maybe you can, pun intended, give us some color into that.
Absolutely. It was actually, I knew from day one that I was going to be in medicine in some way, shape, or form. Actually being a skin of color person from Sri Lanka, we were kind of geared towards two tracks, kind of sort of not just in my family, but culturally in the Southeast Asian community. We are, thinking about either going down the track of medicine or engineering, at least in my family and certainly a larger community. So I always knew I wanted to go into medicine, and I also really wanted to have a family. And so our family moved here from Sri Lanka when I was 5 to settle in Portland, Oregon. And I had several physicians in my family who I love dearly. And I really just wanted to be able to also have a family. And so when I was geared towards going into medical school, and I realized there was I went to University of Portland, there was a very strong nursing program. And nurse practitioners back in the day, I'm quite old, were just starting to get footing. And I really thought that nursing was more aligned with sort of how I wanted to practice medicine and also be able to balance family life. And so I became a nurse first, and I went to work at the VA because I felt a very strong commitment to kind of giving back to everything, being in the United States and having kind of the American dream as an immigrant. So I felt a passion towards working with veterans. And so I started there as a student nurse while I was still in my undergraduate program. And then I went to work immediately upon graduating because as a student nurse, I worked in the HEMONC department. And the VA at that time had two specialty really areas, which Portland was one of the two facilities that was a liver transplant, had a very strong liver transplant program, which back in the day was something new and upcoming. So that's kind of how I put my foot in the door at the VA. And from there, I did med-surg nursing. I definitely knew that I wanted to, advance my education. So went back to graduate program at University of Portland, and they had a strong NP program. So the difference basically between nurse practitioners and physicians and PAs is nurse practitioners, it was kind of founded back in the 70s where there was a real need to extend medicine and healthcare out to urban populations and communities of need. And that was something that really resonated with me. And so the programs were started by a lovely woman who was actually an Army nurse and became a nurse practitioner. And her focus was really expanding, again, medical care out with the proper education to communities of need where there was not a large number of physicians to take care of these populations. So with the appropriate training, the nurse practitioner kind of basis started. So nurse practitioners in most states, I believe we are independent licensed practitioners in about 28 states so far. And in the other states, we are usually working alongside or collaborating with our physician colleagues. And it really has had a wonderful pairing, again, using the interdisciplinary team of all members, nurses, um, physician assistants, physicians, and the entire healthcare team to really expand healthcare to, not only populations in need, but in healthcare in general. We know that there's a huge demand for healthcare, especially in this day and age. So, nurse practitioners really, I think, bring a unique perspective to the healthcare team because we do come with a nursing background. And I think that has really helped me, especially in the dermatology space, which I sort of fell into serendipitously. I had a strong focus towards infectious disease, but I passed a colleague who in the hall actually who said, "You really should go into dermatology. There's a lot of infectious disease, and you love immunology and science, so this would be a perfect fit." And so I applied for the position, and I had a wonderful physician attending who was affiliated with Oregon Health Sciences University. And thankfully, we have a wonderful residency program there for dermatology physicians. And so I trained alongside them about 24 years ago, and that's how I came to be in dermatology. And a lot of great research was happening at the time with amazing scientists, dermatologists such as John Hannafin and Eric Simpson and Andy Blauvelt, and so many individuals who really, were role models for me and really ingrained in me that passion to know immunology and get further learning before we can really understand and be able to bring a rich, robust palette to our patients.
That's an incredible story and really grounded in real need, right? And true education. For those nurses who may be listening to us out there, what is now the path to become a dermatology nurse practitioner? Is it one way? Are there a couple of ways? How does that
Yeah,
work?
that's a great question. So back in the day, most of the requirements for to become a dermatology nurse practitioner required a master's of science. So we have 4 years of bachelor's of science in nursing, and then an additional 3 years in a master's prepared program. Now we've actually elevated that bar to actually having a doctorate in nursing practice, so a DNP, which a lot of people confuse as being a dermatology nurse practitioner, but it's actually a doctorate of
Right.
nursing practice. And then in addition to that, so that's usually a 3-year program and numerous clinical hours of clinical practice. You can get to that. There are now programs where you can go directly from your undergraduate program directly into a graduate program. But most dermatology nurse practitioners have been in clinical practice for several years before they decide to go back to become a nurse practitioner. So we take that kind of rich background of having being a nurse, a registered nurse, however that may look, whether it's a med surge or inpatient hospital practice or private practice or a specialty area. And then they go on for an additional 3 years to get their doctorate program. And then, we do clinical hours, obviously, and then have to defend a thesis. And then, in addition to that, now for the past, gosh, probably 20 years, I would say, we have had an accredited dermatology certification. So, as a nurse practitioner, we are really pushing that bar to not only have a DNP, but also to be a board certified dermatology nurse practitioner. And most nurse practitioners are moving towards that.
Yes, and that field has definitely grown, and I can tell you, all these years working as a physician, I love working with nurses on the floors and all that. There's something about this collaboration that goes back so many years to being with human beings on the floors with sick people at their worst times, right? And we get to share that, and from that grow together as a healthcare team. There's something about it that I think is very unique, and so I feel that we are blessed to work alongside our nurse colleagues together, and now in dermatology. There you go. Okay, so great. Thank you for highlighting these pathways, and clearly this is an evolving field. So fantastic to hear that the field is getting towards more and more specialization and professional accreditation. I wanted to now let's move to our topic because we want to also spend some time on that. Although I feel actually you are the kind of person I feel like I can just talk to and listen to forever. So tell us, why is it so important to recognize the unique clinical presentations in folks with different skin tones?
It's a really important and timely discussion. Back in the day when we started practicing, I know all three of us have been practiced for quite a few years now. When you look and you pick up Bologna or Habif or any of the traditional dermatology texts, there was no internet back in the day when I was training. And you picked up those textbooks and you looked at the derm images because we know that dermatology is a very visual specialty. And it's all about the nomenclature, is all about describing lesions and understanding how to present patients and document them correctly. And it was all about describing the lesions. If you look at those textbooks, very few of those dermatology images included skin of color. Now, as you mentioned, in the last decade, there has really been a revolution in emphasizing skin of color patients in the field of dermatology. Now, dermatology traditionally has been called out publicly as a specialty for not moving forward in this special area. If you look at our colleagues, dermatology, I mean, when we look at dermatology residents, dermatology practitioners, there really has been fewer number of dermatologists, dermatology specialists who are skin of color compared with our other specialty colleagues and our primary care colleagues. So, there was really a lot of investigation and looking into, the number, what were some of the barriers to get people into dermatology, and when a patient presents to us, why are they not seeing a colleague with the same skin of color? So that was one issue that dermatology as a specialty had. As colleagues, when we look around, when we go to attend congresses or meetings, how many of our dermatology colleagues are skin of color. So that was one issue. The second issue, as I mentioned, was textbooks and, um, when we looked at training, how much of training focused on skin of color patients? There was very little. And so that was also a deficit that we recognized in the specialty. The other most important factor is, it is predicted, in the next 10, 20 years, over 50% of the US population is going to be skin of color population. So if we are not having the conversations about this, if we are not recognizing that this is a need for us as a specialty, we are behind the ball. Thankfully, groups such as the American Academy of Dermatology and all of our other associates have recognized this. So there is a large focus and a big push for putting skin of color curriculum in the residency programs and in training programs. If we go to industry lectures, clinical trials are starting to focus more on expanding the population that they include in clinical trials for skin of color populations. So this is real. This is something that is very timely, and it's really important that our colleagues understand that this is the population that you're going to be treating. And when you open that exam door, it may not be the traditional patient that you are used to seeing. Many parts of the geography of the US is not as diverse as, say, New York or California or Florida. There's many populations, including my hometown of Portland, Oregon. We are getting more diverse, but it's still strictly, an underestimated community. So we need to have this focus in our mind of looking at the special needs of our skin of color populations as they come to us for dermatology needs.
Thank you, Lakshi, for this really thoughtful overview. And I want to dig into one of the, I think, key important concept here that in dermatology, the color of the skin we're looking at, be it the background or more importantly, the lesions we're looking at, the color is not just something we, observe. It really, to us, folks who do this for a living, it really tells us what the pathology is. So yes, in theory, we could biopsy every lesion of every patient that walks through the door, but that is not practical. And over the years, we've learned to recognize these patterns. Part of it is based on the color. And when we look at something and see it, red, white, purple, pink, black, brown, we use all these colors. They're not just for the sake of, being academic about it. They really mean something to us in terms of the pathology. Now, if you then take it to the next level, when a person appears in front of you with a lesion of the skin, but the background is different, the background color is different. For example, you have a dark-skinned person with a red lesion. That red may not seem so red as it would like on my skin, right? I'm Caucasian. You see red on white is super easy to see. The contrast is there, very clear to you, and you can differentiate. But if the background gets darker, it gets much harder. And vice versa, if the lesion, for example, is completely lacking pigment on black skin, super easy to see. On white skin, you may need to squint a little bit, especially if there's atrophy there, and so on and so forth. And so now hopefully the audience who's listening to us can start to appreciate that this understanding is not merely academic. It has to do with the core of the practice we do and our ability to really deliver good clinical care to our patients. And so I agree with you 100% about textbook and having this richness of the background of the color in contrast to the lesion in order for us to become more astute clinicians. And just as a fun story, I trained in the Bronx and now I practice in California and in Florida. And when I moved here, I was like, oh my God, now I get it. It's so easy. Seeing red on white is so easy because all I saw was was dark skin. So to me, red on black was something I had to really work on, or even red on dark brown. All these kind of color contrasts. So okay, so we've kind of established why it's important, and now I want to switch gears and understand why it's important when we actually talk about treating these patients, right? So can you maybe give a quick overview about why it's important to consider the skin tone in front of you when you start to prescribe treatments.
Absolutely. And this is really important. So, not only are there, the pathogenesis behind the diseases and the anatomical differences within the skin of color. We're used to categorizing things in Fitzpatrick types, right? 1 through 6. But this was, I think most people don't understand exactly where Dr. Fitzpatrick was brilliant in determining these skin tones and these skin types that we use so often in in our discussion. But what we really don't understand is that Dr. Fitzpatrick actually used those categories to describe the level of ultraviolet rays that penetrate the skin for photosensitivity reactions. It was not used as a rating for the type of patient that is sitting in front of you. So people don't often realize that. They think that this is a very, um, you know, uh, recognized and thoughtful description of how we categorize the person sitting in front of us, as far as their skin type and perhaps their ethnic background. But it actually has to do with the absorption of ultraviolet light into their skin. So I think that's something to be important to recognize. I think the most important thing to recognize is really three things. When we're walking the door, we see a patient, we sit down in front of them, we're diagnosing them, and then we're thinking about their therapeutic regimen. The first and most important thing is actually their skin pathology. There's anatomical differences in skin of color patients. When you're looking at someone who may be a darker skin tone, say a 4, 5, or 6, you're perhaps in your mindset, you might be pre programmed to think less about their risk of skin cancer. Whereas if you saw a fairer person, even though they may have been coming in for, say, psoriasis, you might be looking at their skin for potential skin cancers, but you may not necessarily think about that with darker skin types. So there's a background of our own understanding of the individual sitting in front of us. So kind of the preconceived notions that we bring with us, the unconscious biases that we bring with us. We all do. It's perfectly normal. And I think it's something that's important to recognize. So I think our unconscious biases are one thing. The second thing, as I mentioned before, are the anatomical differences. The darker the skin types, there's actually anatomically differences in both the epidermis and the dermis of the skin. We have more melanosomes that, we all have the same number of melanocytes, but the melanosomes are different and they're in different varying degrees in the epidermis in darker skinned individuals. That can influence the way that our skin pigments and the way that our skin presents skin conditions such as atopic dermatitis, psoriasis, etc. The second thing is there's also a decreased level of ceramides in skin of color. So the darker the skin pigment, we may have less lipids producing that moisturization. Subsequently, these individuals may be at higher risk for having drier xerotic skin. So that's something to consider as we look at these patients. I think more important than ever, Raja and Hadar, that I think about is the cultural differences. And I've become, the more research I have done into this, really asking our patients about their cultural practices. What is important to them as far as how their skin presents? What have they tried before? Are there considerations that they need to think about? Things that we might not necessarily think about that influence their skin, such as how they cover their skin, how they expose their skin, the emollients that they use. As our population becomes so much more diverse, it's actually exciting. And I think Learn Skin and IDS does a great job of bringing this kind of holistic sense of how we talk to our patients about their cultural preferences, their daily practices of skincare. I think it's really important for us to consider. And then finally, I think it's also really important to recognize that, patients, we as providers in the medicine community, we don't realize the perception that we see 20, 30, 50 patients a day. we don't think about that vulnerability of that patient as we open the door and sit with them. They may have been waiting 3, 4, 6, 8 months to get in front of a dermatology practitioner for their very concerning skin condition. They may be frightened. They may be feeling vulnerable. And this is really important, especially if they have a provider who does not look like them or may not be from their same cultural community. So I think taking just a few minutes to ask about their cultural perceptions, their healthcare practices, and even just what they truly want from their visit, I think that sets the tone and makes for a really important, proactive, and therapeutic intervention in just the few minutes that we have with this individual and perhaps their caregivers and their family members.
Oh, Lakshi, let me just say, first of all, what an amazing kind of description of how to approach patients and just put that into the context. I wanted to add a little bit more flavor to the Fitzpatrick skin types. We actually looked at the Fitzpatrick skin type, and I want to clarify the Fitzpatrick skin type because the way we do it now is not how it was originally developed. The way we do it now is, I think, I would say colloquially, as we walk into the room and we kind of try to grade, their sensitivity to sunlight and whatnot. But originally, it was done off of a survey. They're supposed to answer, "Am I really sensitive?" And then a little bit of around the color of their eyes, color of their hair. We actually did this. And we actually did this over a bunch of people, and we looked at what their skin types were, and we used a colorimeter, which would objectively give you back color. And what we found was that the Fitzpatrick skin types only predict color in skin types 1 to 3. When you go to skin types 4 to 6, it's all over the place. It actually isn't that accurate. And I mean, one of the issues right now is this big push is that when we're talking about skin color and tone, the most objective way is to go to like a colorimeter. This whole Fitzpatrick skin type was very weird. When we did the study, this was the most interesting thing, Lakshi and Hadar. I mean, I found this kind of comical. We had people that were clearly very, very, very sensitive, had freckles, very white skin, kind of like that Irish skin that would come in and be like on the survey. Because, you're not supposed to assist people on surveys. They'd say, "Oh yeah, no, I never burn." And they'd come back as Fitzpatrick skin type 5. And I was like, oh, hell no. And then on the other side, we
So
had
true.
people that were skin type 6 and they'd be like, "Oh my gosh, I'm really sensitive when I go outside." And they came back skin type 1. And I'm like, okay, this is wonky and this is off. And actually, when we did the correlation, it was correlated for skin types, especially 1 and 2. 3, it started to really lose its edge. 4 to 6, it was worthless. It was all over the place. And so I think it just goes to show like a skin type 3 and a skin type 4 and a skin type 5 could be various ethnicities of various microtones, various cultures. So Lakshi, I think you nailed it when you started talking about kind of also what's embedded in their culture, what's embedded in their practices. I mean, absolutely just want to wholeheartedly agree and just add a little bit more evidence around the lack of evidence.
And I think that is
And
absolutely fascinating, Raja, and can't even tell you. So the other point is, at if any given season, I am much fairer in the winter than I am in the summer. And so it really matters on the time of year, what their recent exposure has been. So I think that that's such an important factor that you bring in, that it really is difficult to find an objective measure of true skin tone and skin color.
yeah, that is actually very true. Although for me, I gotta say, I'm pale year round. Actually, it just doesn't matter what I do. I wanted to ask, maybe even both of you. A lot of folks who come in are very concerned about hyperpigmentation. So a lot of what we see, right, is post-inflammatory changes. It could be from an inflammatory condition that leaves its mark. It marks behind. Classic among these are is acne, for example, but also biopsy that we do, procedures, scars, and that is a big concern. Can you give us your thought on how to approach this in our patients?
Yeah, I think that that's one of the key and most important factors of this. I've spent a lot of time in my practice dealing with psoriasis, atopic dermatitis patients, and a lot of patients who have these chronic skin conditions. one of the biggest things that just really has had an impact on me is sort of the difference in the way we approach patients. So, back in the day, we had this opinion that, we start low and then gradually increase the therapeutic regimen because we wanted to, give topicals a try. We wanted to do the least harm to patients. If we could avoid systemics, we would. And then thankfully, the research in the last 25 years with the advent of biologics and systemic therapies that are really safe and very effective early on. Uh, the problem with skin of color with our patients is again that hyperpigmentation. And we don't often see this in our lighter skinned individuals. Thankfully, we're able to recover an almost near appearing skin, as we see in many commercials. They return their skin to normal. Unfortunately, with darker pigmented skin, the scarring factor is a real issue, and the hyperpigmentation often lasts longer and sometimes can be absolutely permanent. And this can have a huge impact, a huge psychosocial impact on these individuals, especially if they're young and start having skin conditions. For example, a young child who has atopic dermatitis very severely, which we know can be at a higher level in skin of color individuals. You start by having a child with atopic dermatitis. They're very itchy, they're scratching, and they're scratching so hard that they're causing erosions and open wounds. And I'm speaking from experience. I had atopic dermatitis when I was very young, and it was so hard. I never went to a dermatologist. That was not heard of. And, I was treated with calamine lotion, for heaven's sakes. And I absolutely have hyperpigmentation that is permanent. So, one of the things I think is really important is when we think about starting our patients on therapeutics, especially in skin of color individuals, I think my personal practice has been to treat more aggressively sometimes, of course, depending on the degree and severity and what their preferences are. But I tend to not necessarily have that mindset of going slower and seeing how maybe a topical treats them. If they have already had significant disease, I tend to push for more, say, systemic therapy in someone who I might prolong that. In skin of color because I really do worry about the impact of delayed treatment in these individuals because of that post-inflammatory pigmentation that can be permanent.
Lakshi, we could listen to you talking forever. I mean, you have so many pearls, so much clinical experience. But I just want to say, this has been an awesome session. And thanks for just taking us through this journey of your own experiences within dermatology, but also how we can all be a little bit better and more mindful of our patients. And we want to thank you for joining us on the podcast today.
This was an absolute privilege, and thank you so much for taking the time for shining a light on skin of color patients and their unique needs. And I really feel that Learn Skin has really broadened our understanding of the needs of this community, and really appreciate you taking the time to chat with me today. It's been a pleasure.
And you mentioned one thing that I want to actually touch upon. You said IDS, which is like the magic word for us. So I just want to mention to everybody listening that the IDS refers to the Integrative Dermatology Symposium, which, totally biased, but probably correct, the best conference out there. So when you get a chance, come check us out at integrativedermatologysymposium.com. We have our symposium coming up August 22nd to the 24th, and we'll be in Palm Springs this year. So come out and join us. And if you're listening to this program way in the future, you can still go to the website and find the next one that's coming up. All right, thank you.
And that's a wrap for today's episode. But if conversations like this get you all excited, that's exactly what the Integrative Dermatology Symposium is all about.
And I'm all excited about it. The 9th Annual Integrative Dermatology Symposium will once again bring together clinicians, researchers, and educators who are shaping the future of dermatology. And this year, there'll be a focus on precision, regeneration, and whole person skin health. It's happening, from August the 20th to the 22nd at the Grand Hyatt Indian Wells in Palm Springs, California.
IDS is where evidence meets application. Through expert-led sessions, real-world case discussions, and meaningful collaboration, or in plain English, IDS is where you get to talk to a whole bunch of people who are equally skin-obsessed.
I'm also equally skin-obsessed. If you want to be a part of the largest community in integrative dermatology, use the code PODCAST15 for 15% off registration at integrativedermatologysymposium.com.
That's integrativedermatologysymposium.com. We can't wait to see you there.